Okay, so we are now recording for anyone who's not here or joining us remotely. So we are doing color distribution morphology, which are the things on which we base our diagnosis. Oh, I opened 17 instead of 7.
It said 7 actually.
Did it?
Clicked on it, I think.
Oh, okay. Always contributed by Robert Johnson School of Medicine, and some of them published in Cutis, and we have permission from the publisher of Cutis to use them. And most of them are mine, like this. So. Okay, Derek, what do you see?
I see a bunch of flesh-colored papules coalescing into blacks and kind of a maybe reticular pattern.
Very good.
Like some hair.
And that's probably the primary lesion. Are there secondary changes?
Maybe some pinpoint like ulceration.
Yeah, or I'd say probably a lot of crust. Serum is yellow because of carotenoids, so when you see yellowish colors, it's often serum crust. And distribution may be hard to tell. Hair-bearing area, that's a neck down below, so we're kind of nape of the back of the head, occiput.
Okay.
So, thoughts? So, yeah, so acne keloidalis nuchae. And so what's the pathophysiology of acne keloidalis nuchae? It's the same as pseudofolliculitis barbae, ingrown hairs? Pretty much. But some people just get bumps, and some people get progressive alopecia. Does this person just have bumps, or does this person also have progressive alopecia? I don't see a whole lot of hair up above, right? So this person has progressive alopecia. Those people then, their pathophysiology overlaps with folliculitis decalvans. And they're the ones who get crops of pustules and crusts, big surprise, just like folliculitis decalvans, and then they epilate. Right? So this guy, he oozes, his shirt is all yellow ooze on his collar, and they're painful, and he's progressively losing hair, so what are you going to do?
If it's early, you could try Doxy. Put them on Doxy, steroid
So Doxy and topical corticosteroid, just as you would for folliculitis decalvans, and that absolutely is helpful for a lot of people. Anything else you can do topically?
Clindamycin swab.
Clinda, a little disappointing for this, partly probably because it just doesn't penetrate well. So if you had an antibiotic and you wanted something broad spectrum, remember staph is often at play in folliculitis decalvans, but so are anaerobes and other things. If you wanted something broad spectrum that will penetrate anything, you put it on topically and it just seeps right through. What's your drug? Chloro, right? Chloramphenicol. So for about 70 years, Howard University has had a formula where they take one 500 milligram capsule of chloramycin, chloramphenicol, and they levigate that in a little bit of mineral oil, and then mix that into 30 grams of fluocinolone cream. What you have mixed up costs, what, $20 or less? And you apply that TID, and you have some people who look like this, and within 3 or 4 months, their neck is flat with no pustules. It really works dramatically for some people who are just sinus tracts and ooze and stuff on the nape of the neck. So it's worth trying. And there are some people who you would think it is surgical disease that they have, and yet they respond to that topically. So worth trying. So you guys know what levigation is? Have you ever made gravy? Is your gravy lumpy?
Strain it.
Strain it.
Or you can put the flour in the water together.
Yeah. Okay, so either you can strain the lumps at the end, which is I know people who, my brother cooks that way, or you make gravy that's not lumpy in the first place, where you take a little bit of water and mix it in with the cornstarch or the flour or a little milk or whatever, so that it's smooth before you mix it in the big thing. That's levigation. Right? You take a powder and you make it into a slurry, and then you incorporate that into something so you don't get lumps, right? So the way you levigate for compounding is not, we should do a compounding lab at some point, because given the escalating costs of pharmaceuticals, we are all going to be practicing as we did in the 1920s, right? Going back to some older topicals and compounding things. And we're spoiled here because we have 4 excellent compounding pharmacies in Charleston. You're not necessarily that spoiled other places, but what you need is a metal bowl and a frosting spatula and a little bit of mineral oil and white petrolatum and things like that, and you can compound. It's not that hard. It's like making gravy. And so it's 500 milligrams chloramphenicol, 30 grams fluocinolone cream generic. Levigate the chloramphenicol, it's 1 capsule. Disperse in the 30 grams of fluocinolone and apply TID. And, really can be helpful in some of these people when other things don't work. Okay, what do you see?
I see looks like an atrophic area about a centimeter.
Yeah, and kind of hard to tell, is it pigmented? Is that post-inflammatory change? I mean, honestly, I'm having trouble.
It almost looks like Anetoderma, some kind of...
It does suggest Anetoderma, doesn't it? Anetoderma sometimes is like that, and often it pouches outward where the fat herniates. But you can have a flatter, wrinkly Anetoderma look like that. So, suggest something maybe that's destroying elastic fibers, which is, any acquired Anetoderma would be in that camp. Certainly if it's growing or progressive, we're probably going to biopsy, right? And this one turned out just to be Anetoderma, right? So Anetoderma can be sessile like that, and any time that a diagnosis pops up like that, it means it wasn't something you necessarily could get just on color morphology distribution. There was a biopsy that took place, or additional history or something. So in this case, a biopsy, and elastic tissue's absent. So Anetoderma can be primary autoimmune, it can be secondary. The most common Anetoderma we see is post-acne Anetoderma on the back, and where you have tiny little shiny, they look like papules, but it's really just pushing outward because you have no elastic tissue anymore in there. And then you've got the Yadison and Schwenninger-Butzi types, where you've got, either with or without preceding urticarial lesions, and it's a neutrophilic infiltrate that just eats up your elastic fibers, and it's autoimmune.
So, looks like we kind of have a well-defined patch of alopecia. It's tough to say if there's maybe some atrophy there. If this was a kid, you would think of like aplasia cutis.
So aplasia cutis, or even an adult, it may be an aplasia cutis. So what suggests something like dysraphism or aplasia cutis rather than an acquired scarring alopecia?
So there's like the hair collar sign.
You got a hair collar sign, right? So acquired scarring alopecia, there's usually a decrease of hairs even at the periphery of the lesion where there's partial involvement. And in congenital malformations, you tend to have a hair collar sign where there's an accentuation of hair around the periphery, and it's often darker, thicker, longer. And that suggests, neural tube defect, spinal dysraphism, congenital anomaly. Sometimes these are underlying meningocele or rudimentary meningocele, or just aplasia by itself.
Looks like you have some hyperpigmented, like atrophic plaques on the back.
Thoughts in terms of...
How do you do Acropoderma?
Yeah, so I mean, your top thing would be Atrophoderma piscineum-perini, which is represents a variant of what other disease? Morphea. It's basically atrophic morphea. Some of them are Borrelia associated, especially in Europe, not so much in the U.S. You got someone who has rapidly progressive disease. They're popping up all over. The patient hates it. Wants it gone. Yeah, methotrexate or UVA1 are probably your best. And since we don't have UVA1 here locally, it would be methotrexate. You can do just regular UVA, but UVA1 high, you can deliver higher doses with UVA1 machines.
You say we might get one of those?
We're going to try. Geisinger did it through Children's Miracle Network, where they did it really for children with GVHD. And then, once you have the machine, they're fine with you using it for anyone. But it's the sort of thing that serves an unmet need in the community. You're never going to recoup your costs, so it has to come through philanthropy, basically. But there are groups that are always looking for things, groups who are around cancer in kids or other things, and they're looking for ways to help the university and donate, and so that's what we're going to try.
So you have a crusted papule on the helix.
Yeah, and the crust is a little bit adjacent to, rather than surmounting the papule, but probably related. And so thoughts?
Probably CNH.
Yeah, probably chondrodermatitis. So what's the pathophysiology of CNH?
You said pressure ulcer.
Yeah, it's the world's smallest decubitus ulcer, on the side where you sleep typically or hold your phone all the time. So treatments for it?
I think Dr. Cook is big on maybe like nitrogen, like paste,
what we've done over the years, we've done a lot of nitro paste for it, and the nitro paste, you get some positive benefit in some patients, and everybody gets a headache, right? Everyone gets a nitro headache. But for some of them it's worth it, because they do get, it's ischemic, basically, right? And so the nitro paste will dilate blood vessels that are there. Now, when you look at it histologically, what are you going to see?
Well, you'll probably see an ulcer, and you'll see like the fibrin.
Yeah, so you got a big column of fibrin flanked by what's on either side of the fibrin? Granulation tissue, right? So vessels. So you already have lots of vessels there that the body's doing reactive to the ischemia. You can dilate those a little bit, but the nitro paste isn't going to get rid of the fibrin, right? That fibrin core has to resolve. So the best thing is, if they can train themselves to sleep on the other side, it's going to go away. Try to do that with yourself. It ain't easy, right? We are creatures of habit, especially when it comes to sleep. So
Special pillow or
there are pillows with a little slot. The ear will stay in there for a while.
What Timolol? Has anyone tried the granulation tissue?
We have. We've tried. The problem with timolol is it stops the granulation tissue, but here the granulation tissue is just reactive to the ischemia, right? So, we've tried just about anything you can think of topically. A lot of them resolve when you shave them, right? And it's partly when you shave them, you just made it sore, so they start to sleep on the other side. And the other thing you can do, especially when it's further down on the ear, you can shave down or just cut out, fenestrate a window in the underlying cartilage. They look a little funny when the sun hits them from behind because it's obviously got a hole in their cartilage. But otherwise, you can't see a defect, and it takes all the pressure off. Just fenestrating, creating a little window in the cartilage, then there's no pressure there when they're sleeping on it. And so you definitely can do that as well. Anytime you're cutting into cartilage, you want to use topical gentamicin post-op or dilute acetic acid. And if you do dotacetic acid, the little formula comes up and you can put it in the patient checkout note.
Have you used PDT ever? There's an article in the JAD showing like 75%.
Yeah, there are articles for and PDT has been used for everything from lichen sclerosis to MF to CNH.
It's just so expensive.
It will destroy lesions. Getting it approved is often an issue. And anywhere where you have an increased blood flow, so you have increased temperature, when you look, you see a little erythema at the base. That's going to translate to increased temperature. Remember, the conversion with PDT is all temperature dependent. So if your regular skin surface temperature, you get almost no porphyrin. Anywhere where you're a little bit hot, you're going to get porphyrin forming, and that's what's going to get killed. A lot of the way it works in AKs is probably the inflammatory base of the AK, that they're hotter. Right? For things like DSAP, we usually have to do it under occlusion and heating pad to make it work. Remember, your ruddy patient with a really red face is going to experience extreme pain and yell at you and say, "How can you do this? This is so painful." And your cool gray-faced patient is going to say that treatment did nothing, right? You got to adjust the temperature.
What about cryo?
I've seen a couple articles on cryo. I haven't seen a lot.
Okay.
Yeah, in my hands, just shaving the thing off solves
Sometimes
the
it can
problem
be
most of the
different-
time.
Hard to differentiate from like that and a spleen. I feel like.
That is true, and that's often why we're doing the biopsy,
Yeah.
is to confirm the diagnosis, but it's both diagnostic and therapeutic
Okay.
for many patients. Okay.
Because of the year, some flesh-colored papules.
So some flesh-colored papules. Anything else about them morphologically? Do they ablate the follicular orifices, or are the follicular orifices preserved within the papule? They're preserved, which is a little unusual, right? Anything that ablates the papillary dermis is going to ablate the follicular orifices. This would be something that at the very least has a Grentz zone. So things with a Grentz zone like granuloma faciale, you see patulous follicles. Things with no Grentz zone ablate follicles, right? So this is something that preserved adventitial and papillary dermis histologically. So you can start to look at it and think, well, I know at least histologically there was a Grentz zone of whatever the process was, right? And you'd probably biopsy, right?
Yeah.
And these were connective tissue nevi. So connective tissue nevi are going to be deeper in the dermis. They often have a shark skin appearance, so instead of being just shiny and flat, they're often pebbly. Why are they pebbly? Because they're in the dermis. They have a Grentz zone. They preserve the papillary dermis, so follicular orifices, skin cross-hatchings, a lot of that is often preserved. So shagreen is shark skin, and so shagreen patch means a shark skin looking patch, which is the connective tissue nevus. That's pretty much a pure collagenoma in tuberous sclerosis. Most connective tissue nevi have increase in both collagen and elastin, and then which one is purely elastic? Buschke-Ollendorf, where you get osteopoikilosis. Okay, Sarah.
This looks like papules, maybe a tiny vesicle.
papules, maybe, I missed the word. I think.
Is that a vesicle?
Oh, so vesicle or crust or maybe even something being extruded out of the papule, could be any of those things. And then how would you describe the border?
So like serpiginous.
Sort of serpiginous. So, any thoughts? So EPS, which is elastosis perforans serpiginosa, would be, you get little papules that look like something's coming up out of them, and they're in a serpiginous array. What's the most common site for EPS? Yeah, usually retroauricular. So side of the neck, retroauricular is overwhelmingly your most common site for EPS, elastosis perforans serpiginosa. And what things are associated with EPS? Is it just a thing treated, or do you have to look for associations? So there are a million different mnemonics for it, and we use rap moped, but they're all kinds of different mnemonics. Pick whichever one you want, but you need one because you need something to prompt you. So what are the things? Rothman-Thompson syndrome. What else?
Marfan's, Downs, acrogyria.
Marfan's, Downs, acrogyria.
Scleroderma.
So, it's one of those.
Yeah.
There are certain things where you got to look at them. There's a whole list you have to think of. You don't want to miss one on the list. So you have a little mnemonic, and you just memorize them, get over it, and because it's clinically relevant, right? What other things? What if it's not EPS? What else could it be?
Feels like Pushlightia, maybe.
Yeah,
So
I mean,
Miyake's.
absolutely. So Miyake's
What else?
granuloma. So what if that's really just scale on the edge? Miyake's fungal granuloma. So where's the granuloma in Miyake's granuloma? In the name, right? Not in the tissue. It's a suppurative folliculitis. So it's Miyake's suppurative fungal folliculitis. There ain't no granuloma except in the name, right? Just like granuloma faciale. The only place there's a granuloma is in the name. So those two would probably be my top. I'm probably going to do a biopsy for confirmation, right? And this did turn out to be EPS in an unusual location. Elastosis perforans serpiginosa.
On the bilateral legs,
Yep.
we have almost faint erythematous macules of
Yeah.
patches.
So there's definitely some inflammatory component. Anything else that you notice?
I don't know, it looks almost like it's atrophied in some areas or depressed.
Depressed. And the depression, are they circular? Are they linear? Are they an anastomosing linear pattern? A branching linear pattern?
They look almost branching linear.
Like a branching linear pattern. So what things could a branching linear pattern of depression correspond to?
Morpheus more circular.
Morpheus more circular. Are there any types of morphea that would give you a branching linear pattern of depression? So what's branching and linear in the skin? The vessels that run in the septi, right? So you think of things that would be vascular or septal if you've got something like that. So morphea profunda or eosinophilic fasciitis, because they're down in the septi, they often tug down and you get that branching, depressed, it's sometimes called the dry riverbed sign, where it all gets tugged downward. What other things, what other fibrotic processes favor the septum?
The deep sarcoid or area.
So Dario-Russi sarcoid, although that's often nodular, but it can be in the septum, so it could.
Erythema nodosum, septal.
Enodosum is a septal paniculitis.
That's weird.
Usually it just looks bruise-like or nodular, but occasionally, because it's in the septum, it could.
It was lupus paniculitis.
A lupus paniculitis could conceivably. The other thing is what fibrotic, a fibroblast-rich CD34 positive NSF, absolutely. So for the first years, what's NSF?
Nephrogenic
That,
systemic.
I see it on my knives. It says that they're certified for commercial kitchen use, right?
National
It says on there, but National Sanitary Foundation or whatever. But our NSF is different, right?
It's a nephrogenic systemic fibrosis.
Nephrogenic systemic fibrosis, which is caused by gadolinium in largely Omniscan. It was largely one particular imaging agent where the gadolinium was more easily displaced. And most of the patients had low renal clearance. So most of them had GFR less than 50, and a lot of them was way less than that. So a lot of them were renal disease, which is where the nephrogenic came from. So it was first described as nephrogenic fibrosing dermopathy, which were just plaques, some of them in the septum and some of them causing depression. And then came the recognition that some of them had systemic disease, so it was called nephrogenic systemic fibrosis. Not that they had to have systemic disease, but it brought attention to the potential for systemic disease. And then, Rob, you want to comment on gadolinium-associated plaques?
So we just reported 2 cases. Like one patient didn't have renal disease, and they just had these discrete, like circular plaques on the extremities, and they had no signs of any systemic involvement. And on PATH had these sclerotic bodies in the dermis, and so we found that like those sclerotic bodies were essentially just gadolinium deposits with high levels that were confirmed with mass spec. And
so, whether or not that's distinct from nephrogenic fibrosing dermopathy, the association with gadolinium with a very slick new technology was done, which is worthy of dissemination, that knowledge. And the lollipop bodies or sclerotic bodies are osteoid, and then you've got elastic fibers that stick like the stem of a lollipop into that osteoid. So it's like an osteoid lollipop with this stem of elastic sticking out of it. So sclerotic body or lollipop body, and it's osteoid, and someone not getting what the humor in what he was saying made the comment at the first consensus conference on NSF that every example they had with this turned out to be a bona fide example of NSF, and yes, they were bona fide. It's osteoid, right? But exactly. So, if it helps you remember it, yes, they were all bona fide examples of NSF. And this one turned out to be eosinophilic fasciitis, but morphological. So you got color, morphology, distribution. You had some erythema suggesting there was an inflammatory component, and you have that branching depression suggesting it's either centered on vessel or just in the septum itself to give you that morphology.
So let's say we're on the face, and looks like there's some open comedones, but also maybe some brown papules or papules.
Yeah, so maybe some papules, definitely comedones, and color. So we've got distribution, which is lateral to the eye, right? Sort of temple. And then we've got morphology, and then we've got color. So how does it relate to the surrounding skin?
Well, the papules are open comedones are brown, but the underlying skin is maybe a little more like yellowish.
Yeah,
than
kind of yellowy,
the regular
right? So what things are going to give you a yellowy appearance in skin? There are only certain pigments in skin. So red is oxygenated heme, purple is deoxygenated heme, brown is either melanin, hemosiderin, or lipofusion. There are only three. And yellow can be what things?
cholesterol. Like
So lipid, and why is lipid yellow? Because carotenoids are lipid soluble as well as water soluble, and so they often give the yellowy color. So have you ever seen butter that is winter butter where they don't add coloring? It's stark white, right? Butter is yellow because of the carotenoids in the meadow for the cows eat, right? If they're not in the U.S., manufacturers or dairies are legally allowed to add food coloring to make butter yellow. Why was that so important? You don't know how fresh the butter is. They can freeze it and they can sell you winter butter in the summer, and you don't know. They can keep it fresh by freezing it, but people don't want winter butter in the summer, right? So they make it yellow year round by
very
adding carotenoids, beta carotene. Right? So just a way of remembering that most of our yellow pigment. Why are granulomas apple jelly when you press the blood out of them? Because they're carotenoids dissolved in the cytoplasm of all of those histiocytes, right? Same reason that lipid appears yellow. And then another thing that can appear yellow is elastotic tissue. So nodular elastosis, you're often rule out basal cell, but one of the hints is it's a little more yellowy. It's pink, but it's also a little yellowy pink, the nodule, and turns out just to be nodular elastosis rather than a basal cell. So if this is nodular elastosis with cysts and comedones, then what is that? You don't want to check it? Favre-Rocachot syndrome. And what causes Favre-Rocachot? Smoking. So there's smokers' blackheads, right? There is actually very poor association with sun exposure, although a lot of smokers are outside smoking. But very, very strong association with smoking. And the wrinkling, that kind of deep elastotic wrinkling, also has a very strong association with smoking. Right? So that's a smoker's face. And what's in the smoke that's causing it is organochloride type of compounds. So it's basically a localized form of chloracne. And you see it, and you see wider spread chloracne in people who have dioxin exposure. So Agent Orange, this probably is just localized chloracne from smoking. And then wider spread chloracne you can get from an industrial exposure or people who are Vietnam vets and had exposure to Agent Orange.
So, not sure location. It might be on the back. So it might be
Yeah, it's a bra strap.
But there's a number of large, dome-shaped. They're plaques. They're almost nodules.
And when you say dome shape,
Right.
all the domes that I have visited, the center is higher than the periphery.
Okay. So almost donut-shaped, perhaps.
Yeah, these have a depressed center, right? So this is something where the edge is higher than the center. So it's a
Right.
plaque with a depressed center, maybe dome-like periphery,
Right.
but depressed center, which is a clue to diagnosis as well. And then just as the center, so this is more expansile than that,
Right.
When you look at diameter, it's more expansile than the center.
Right.
So it has a dumbbell appearance where it's more expansile at the edge. So dog bone or dumbbell appearance where it's more expansile at the periphery than centrally, suggesting maybe there's an active proliferation
Right.
out there at the edge. So
The closest thing I would know would be a keloid, but I imagine
Yeah.
it's more complicated than that.
no, I mean keloid would be typical for that. Other things that can do that, KS can do that. And then what's our most common keloidal deep infection?
Lobo.
Lobo. So lobomycosis, which is becoming more common. So lobo you get in tidal estuaries when the population goes up and you have more and more fresh water, especially sewage effluent going into those tidal estuaries. So I don't know if you know any tidal estuary area where the population's been booming and there's a lot of construction, but those are the kinds of places where you might encounter lobo, right? And then lobo looks keloidal clinically. So, I think common things being common, that's just a keloid.
All right, so I'm not sure the location, but you have this kind of well-defined kind of lilac violaceous erythematous
So
plaque.
lilac. So you're saying it's not cherry red, it's lilac. And lilac, what do you associate lilac color with?
Usually morphia.
Yeah,
Morphia-like.
I mean, it's the tagline for morphia, especially when you see a white sclerotic center like that, right?
Yeah.
But what other things have an identical color, even though we don't
So-
necessarily use that name?
Extragenital, lichen sclerosis would be
Lichen sclerosis can.
something I would think about.
What else, though?
With
Without the sclerotic center, just that color.
yeah, that color.
To me,
Maybe like
it's-
cranial facial or
no, to
or-
me it's the color of lupus and dermatomyositis as well. So if you just, even though we use the name lilac when we're talking about morphia, it's the same color of lupus. It's the same color as dermatomyositis. So, go to Sherwin-Williams, get that paint chip, and write connective tissue disease on it and stick it in your pocket because that's, it's often the color. You've got that neonate and it's not really annular. And there's something that just is, this looks like something that I ought to recognize. And then it hits you, dummy, it's the color. It looks like lupus color, right? Like connective tissue color. Because it's not really red. It's not really pink. It's kind of lilac. Just a little bit of violet tone on top of pink.
Mm,
So
Same.
these,
different patient.
Different patient.
see, all the digits are kind of thickened. They're kind of white, sclerotic looking, kind of sausage-like. Nails appear rounded.
Yeah, you have hypercurvature of the nail. Proximal nail fold completely normal.
No, there's so I'm not sure how to describe it, but there's some white deposit.
Yeah, there's certainly ragged hyperkeratosis is sometimes used as a descriptor. Are the nail folds evenly white, or do you see areas that are too red?
Right.
So there's erythema of the nail fold, and is it all too red, or are there areas of white in there too, where it's not enough red? Like right at the base of the arrow there, and right there, and right there, and right there. So you have alternating erythema and what is probably scar or, anemic areas next to erythematous areas, suggesting some pathology of the vessel. Sometimes you can even see telangiectasia, so dilatation and dropout as part of that phenomenon. Color-wise, cherry red?
Yeah.
I don't know what cherries you're eating,
Purple.
but yeah, a little more violaceous maybe. In fact, not too altogether different from the last patient's color. right? So, you know, maybe a little lilac, or pink with just a little bit of purple. I actually had one resident who took an experiment. They took finger paint and mixed it up. This was a half cup of pink and a teaspoon of purple. Was, you know, basically the proportions to get you to about connective tissue disease color. So, any thoughts what these fingers might be?
I mean, it's Scleroderma.
Yeah, exactly. Progressive systemic sclerosis, Scleroderma, crest could look similar, right? But something in the Scleroderma spectrum. How would it look different from a, so Brian, how would that look different from a dermatomyositis hand? That gets ragged cuticle, that gets dilatation and dropout, right?
Yeah. I don't know. I thought it was actually going to be mechanics hands.
You thought it was going to be mechanics hands
Maybe.
of DM?
Yeah.
Things that I would say is the hypercurvature of the nail,
Mhm.
that's much more a Scleroderma feature. And you can get under that nail, there's probably an inverse pterygium, right, where your nail bed is really sucked up to that nail. That's much more Scleroderma spectrum, that kind of nail change. The other thing is if there's sclerodactyly there, that's Scleroderma spectrum, not DM. So, you know, feel the fingers. If that's a hard, tapered digit, and these, I think these really look like they taper with loss of flesh towards the end. That's, again, more Scleroderma spectrum than DM. And mechanics hands, where is the hyperkeratosis typically?
It's usually mostly just digits, like across the
And
digits.
specifically, it's the, if you make an L with your thumb and index finger, it's the inner surface, it's those connecting surfaces. So it looks like you've been, you know, grabbing something and giving it torque, which is where the name mechanics hands came from. So it's a hyperkeratosis of the medial surface of the medial side of the thumb and the thenar side of the first digit, that line of hyperkeratosis. And do mechanics hands, do they correlate with anything particular?
Usually like lung involvement or anti-synthetase.
Yeah, they're a marker for anti-synthetase syndrome, which are often our sicker patients with lung involvement. The other ones, if you have someone, say this was really a DM patient, but they have hands that have pits and start to look kind of Scleroderma, then you're also thinking of the MDA5 patients, which tend to be, again, a group of our sicker patients with dermatomyositis, and they have lots of Scleroderma features, especially digital pitting. And the digital pits tend to be very painful because they're ischemic. And so this, you know, sclerodactyly was kind of the key here, that it's probably more likely a Scleroderma hand.
So this looks like kind of yellow-brown indurated appearance. I don't think it's scale. I think it almost looks more star-like.
Yeah, so the question is that pigment incontinence, or is that hyperkeratosis giving you hyperpigmentation? You know, you can get either mechanism. Some of it, the way the light reflex is, some of it looks like maybe it could be hyperkeratosis, and other looks like it's probably pigment incontinence, right? And it's reticulated.
I mean, it's not quite leopard look, but I think about connective tissue type.
So poikiloderma from connective tissue.
Especially
The reticulated appearance would be, you know, you certainly can get that. A little unusual in that, but you can. And when you're saying connective tissue, you're really, if you go to the histology, what kind of histology are you saying gave rise to this most likely?
like some sort, like not some melanophasia, some sort of like lichen or like destruction of.
Yeah, interface of
Yeah.
some sort, right? So if you're saying pigment incontinence, you're probably talking something that wiped out your basal layer, so some kind of interface process. So what other things would be lichenoid? In fact, just go to your histology. What's your lichenoid differential diagnosis? What things give you lichenoid?
Could be GVH too, but
So graft versus host, that now puts that way up in my differential, right?
yeah.
That this could be GVH because of the things that do that, lupus, and you mentioned connective tissue disease, like lichenoid drug, lichen planus, things like BLK, lichenoid regression of melanocytic, that's not likely to have this morphology, but GVH certainly could. So that probably goes up to my number one then. Because I'm seeing it clinically, I'm picturing the histology in my head, I see areas that look like they're probably going sclerotic, I see reticulated things. So now I do sclerotic plus interface. That's probably chronic GVH, or more likely than some other things. Let's see what it actually was. This was GVH.
Wow.
One of the other things that helps with GVH is as it becomes sclerotic, it often has a corrugated roof appearance or a ruffled potato chip appearance. So when you look at these, see how it looks kind of striate? So all those sclerotic areas, it's not uniform. It's parallel ridges, just like ruffles, just like a dip chip, right? So corrugated roof or a dip chip, where you have those parallel rows of sclerosis, is very characteristic and suggestive of scleroderma and GVH. So here, reticulated erythema, combination of hyperkeratosis, pigment incontinence, all suggesting interface, sclerosis that is in linear ridges like the Appalachian Mountains.
What do you do for these patients?
Ooh, they're tough. So usually light to start because a lot of them are light responsive. Some have to go on to PUVA, but most are narrow band responsive. And that is the lion's share of what we contribute. Some also need systemic immunosuppressive therapy sometimes for their GVH. And when it's horrible, you can do things like cyclosporin that work for anything lichenoid. The problem is the people with GVH, they're often getting a good graft versus tumor response as well, and they are hesitant to ablate that graft versus tumor response. So if we can treat it with light, we're not harming the graft versus tumor response and still helping the patient. So that's it's usually in the partially effective range, but it can give a lot of relief of symptoms and it's not compromising their cancer therapy. So that's usually about the sweet spot where we are. We have one person with horrible scleroderma and GVH that were regular light just wasn't cutting it because she was too deep, and narrowband doesn't go that deep. But you can then either do PUVA, which she did not want to do. She's very outdoorsy. She wins rowing. Her team wins sculling competitions. And that's really important to her identity and her well-being. So, we really didn't want to do PUVA where there's a lasting photosensitizing effect. So we're doing eczema for her, where you can get deeper with, and she's getting really, we're putting some mileage on that laser because we're doing broad areas on her, but you can get way deeper. You're only getting papillodermis with, and like in a thick hyperkeratotic palm with psoriasis, you're not even getting through the corneum with narrowband. But with eczema, you can drive it deeper. And so palms will respond to, palmar psoriasis will respond to eczema. And at one time they sold units that were hand-foot units that were narrowband. They didn't work well, just because you can't get deep enough for most of the disorders that you're trying to use it for. And so when we're hand-foot light, we're either eczema or we're a UVA, a soak PUVA, because UVA light will go down to bone almost, whereas narrowband has very limited penetration. usual delivery of hair. Okay, how about this?
So, the baby with, looks like almost petechiae, but then larger areas of, so we'd say it's more like purpuric on the lower abdomen.
Purpuric or just dusky erythematous,
I guess
and then
that's here.
epithelium intact or epithelium not intact?
Well, on the knees it looks like it's coming, definitely coming off from the edges and not intact.
Yeah, peeling off and brown. So peeling off and brown suggests that it is dead, right? So death of the epidermis.
And with like the brown flaky paint, you think of like a protein deficiency.
So
like a
you could,
nutritional, specifically protein.
so flaky paint you get with kwashiorkor. Kwashiorkor is pure protein. Marasmus is protein calorie deprivation. Kwashiorkor is pure protein deprivation, seen still in parts of the world. We see it on infants whose parents are giving them soy milk and things instead of formula, and the soy milk doesn't have, there are all kinds of things, you know, there's not a lot of protein, there's not a lot of zinc, there's not a lot of all kinds of stuff in there, right? And so you see little malnourished kids because of that.
Zinc deficiency.
So zinc deficiency, like acrodermatitis enteropathica, and that tends to have a more periorificial and acral distribution, so it would actually fit very well with what we're seeing, right? So this, especially if the kid has diarrhea, this is probably acrodermatitis enteropathica, right? The acro in acrodermatitis is the acral and extensor distribution. The enteropathica part is the diarrhea and the like, and the poor absorption of the zinc. So this is almost certainly acrodermatitis enteropathica. Histologically, what are you going to see?
You're going to see pallor of the upper half of the...
Yeah, pallor and death of the upper half to third of the epidermis. And what else looks identical? And then later on, it's just a compact parakeratosis that you can see. What else can look identical histologically?
When you think of like depth of the epidermis, you think of like an EM like spectrum, but I mean,
That's usually individual cell necrosis.
Right.
Zonal necrosis of the upper third. Anyone want to jump in?
Glucogonoma or necrolytic.
Glucogonoma, necrolytic, acral erythema, necrolytic, migratory
Migratory
erythema,
erythema.
right? Necrolytic, what does necrolytic mean? It means usually the upper part of the epidermis is dead and lysing, right? It's necro and it's lysing, right? So this kind of peely, dead peely skin look is necrolytic. So necrolytic migratory erythema tends to be a centripetal distribution, especially flexures, and intertriginous areas, and is associated with deficiency of amino acids because of a glucagon-producing metastatic tumor. What's necrolytic acral erythema a sign of?
Hepatitis C or B?
Hepatitis C.
C.
You are correct, hepatitis C. And
Harden up.
the what does your patient look like? Is it a little white kid like this?
It's me like a older white male, probably with plaques in the flexural, like behind the knee.
That would be your necrolytic migratory, your glucagonoma patient.
Acral. Oh,
would
acral
be
foot, hands
an
and foot, yeah.
asthenic, necrolytic acral,
Is it back of the hands or?
dorsum of hands and
Dorsum of
foot, and
hands.
what does your patient look like? Little white kid,
Older male.
older black male.
Black male.
So usually, we say African American. In publishing, they say black because apparently African American is very, very offensive to the Africans who are not American. Right? That's a very North American centered terminology where everyone is a hyphenated American. And the Europeans say We have Africans. They're not American, right? So in publishing, they've gone back to black and white as kind of the standard terminology. But it's actually in necrolytic acral, it's more just darker skinned because it was first described in Egypt. So it's first described among olive-skinned people. So you see it in people of Mediterranean, Southwest Asian type descent. In our population, we tend to see it in older black males with Hep C. But it's usually a darker skin type, acral, Hep C. A skinny patient losing weight doesn't look well. Centripetal, flexural, glucogonoma. Little kid, extensors, end flexural, end periorificial, horrible diarrhea, failure to thrive, zinc deficiency, acrodermatitis enteropathica. Although it could be any nutritional
Can you
deficiency.
check for like cystic fibrosis in those patients?
Yeah, I mean that's one of the causes is cystic fibrosis. As they get older, cystic fibrosis, the difference is horrible, horrible constipation with cystic fibrosis as opposed to the diarrheal illness with acrodermatitis enteropathica. Plus they're rusters. Everything they touch rusts because they're too salty. So that's why the sweat test.
Caleb pointed out a good point. You can kind of see the diarrhea maybe.
Actually, that probably is a little diarrhea right there on the sheet.
Context clues.
A little bit of a crappy observation. Diagnostically very useful in this case. So that was acrodermatitis enteropathica. Okay, how about this one? And this is our last one because of time.
So it looks like we had like a purple to pink, kind of like a patch, and then some areas of erosion.
So areas of erosion.
We're on like the lateral.
And do you think this is real healthy,
No.
thriving alive?
Looks pretty necrotic.
Looks pretty dead,
Yeah.
right? So what word do we use for death? Necrosis. And this necrosis, is this circular necrosis? Is this, what's the morphology?
Kind of retiform.
Kind of retiform. Retiform meaning net-like, right? And individual lesions are kind of stellate. They have arms like a starfish, right? So stellate necrosis merging to retiform necrosis. What are your broad categories for retiform necrosis?
So vasculitis.
So if it's vasculitis, is it postcapillary venal disease? Never. It's what?
It's usually more arteriolar.
Arteriolar. So what things would be included in that differential?
So like sepsis.
Septic vasculitis. What else?
Rheumatoid.
Rheumatoid and
Angas.
and all the ANCA-associated
And like
vasculitis.
PAN, given the distribution, kind of.
Any
proximal
drugs that can give you that kind of arteriolar side vasculitis? Two biggies, propylthiouracil and montelukast are the two biggies that give you an ANCA-associated retiform purpura type of drug-induced, like a pseudo-Churg-Strauss, exactly. With your ANCA syndromes being Churg-Strauss, what used to be called Wegener's the Nazi, so it's now granulomatosis with angioitis, polyangiitis. And Churg-Strauss, she was female at Mount Sinai, and he was also a New Yorker, but they were not bad people, so you can still call it Churg-Strauss. And then microscopic polyangiitis, PAN being the last one. Okay, but what if it's not vasculitic? What other things give you retiform purpura? Embolic disease, things like cholesterol embolism. Embolic tends to have what distribution? More distal, acral. So embolic disease is characteristically acral retiform purpura. And then what else? What other group? Thrombotic. So thrombotic, which includes things like coumadin necrosis, levamisole toxicity, where you have widespread thrombosis, and levamisole's in what? Coke. Yeah. So coke snorters, cocaine, they get retiform necrosis on their ears and proximal and extremities. They can get it anywhere, really. But retiform necrosis is typical for levamisole, cocaine, toxicity, thrombosis. And what if this is rock hard retiform necrosis? Calciphylaxis. So calciphylaxis, so embolic differs from the others in that it's distinctly acral, and calciphylaxis differs in that it's a rock hard retiform necrosis. And you can't really feel the slide, so but my guess on the thigh would be if that's hard, it's calciphylaxis. If it's soft, then I'm thinking coumadin necrosis and the other things we've been talking about. What's the difference between heparin necrosis and coumadin necrosis in terms of things you have to look for in the patient, systemic associations?
So, I'm not sure on the coumadin. I know heparin, don't you have to, like, because the coumadin is the protein CNS.
Coumadin is protein CNS deficiency, temporary, and do you have to stop the coumadin? No, you treat through. You treat through. Because if you stop the coumadin and you have to start it again, then you're starting all over again with your decrease. So protein C and protein S will drop. They're your anticoagulants. They drop before your clotting factors drop. And so you get that window. So coumadin necrosis overwhelmingly occurs in people who weren't heparinized first. So they didn't have a transition to coumadin, right? So they have their anticoagulants. Anticoagulation hasn't really happened yet, but your protein C, protein S have dropped. And then heparin necrosis.
You get the antibody to the platelet.
Antiplatelet. So you have not only thrombosis, but you have the risk of life-threatening cerebral hemorrhage because of the antiplatelet antibodies. So in a heparin necrosis, you must stop the heparin because of you have both a thrombotic and a bleeding risk because of the life-threatening potential autoimmune thrombocytopenia. Okay, excellent. So this is so we're on set 7, slide number 24 will be our next one. So we got through 24 today, but a lot of them had more stuff to talk about. When we're really cooking and it's just morphology, we can get through 75 a session.